Sorry about that. Annie's always said that I have a problem with mumbling, so I guess the technology just can't keep up with that. So we're a little behind schedule, so I'm going to, it's great that we've been having a discussion because that's more important than being on schedule, but I'm going to go through these next ones, try to go fairly quickly and see if we can catch up. So why MDMA for PTSD? You know, all the therapies basically for PTSD involve revisiting the trauma in a therapeutic setting. And some of the reasons for not having that work are, you know, too much fear. People can be overwhelmed by the fear and anxiety, so they're not willing to do it. Or if they do it, if they revisit the trauma, it becomes re-traumatizing. And there's, you know, lots of data about, like in exposure therapy, that it doesn't work if people are over-aroused or over-engaged. Conversely, there can be a lot of defensiveness and the emotional numbing we were talking about. So if people have a lot of that, they may be able to talk about the trauma, but if they're not engaged emotionally, it's not therapeutic. And also the problem of lack of trust. People with PTSD tend to have a problem with trust, and that can be an obstacle to successful treatment too. So if MDMA can increase fear and defensiveness, decrease fear and defensiveness, increase trust and empathy, that could allow for processing of the trauma within what's been referred to as the optimal arousal zone or zone of tolerance. This is a slide adopted from Pat Ogden's book, and you know, it basically shows this is the kind of a continuum of arousal, hyperarousal up top, with you know, increased emotion, emotional reactivity, hypervigilance, and disrupted processing. Down here in hypoarousal, kind of relative absence of sensation, numbing, and disabled processing. So in the middle is this optimal arousal zone. That's where the therapeutic change happens. And that's been described in other kinds of therapy. So if MDMA, the thinking is if MDMA can give people a period of time in this optimal arousal zone, it can overcome the obstacles for successful treatment. There's also another way to look at it, the neurocircuitry model of PTSD, which is about deficit and extinction of fear conditioning. And it's been shown in people with PTSD that there's decreased activity in the prefrontal cortex, increased activity in the amygdala, smaller hippocampal size. So that modulation system of the emotions is disrupted in PTSD. So far, we haven't studied people with PTSD before and after MDMA, but that's going to start to happen in Israel. But people with PTSD, MDMA has been studied in normals, and it's been shown that it causes, among other things, increased activity in the prefrontal cortex and decreased activity in the left amygdala. So that kind of fits with the optimal arousal zone idea, and it also fits with the idea that, well, if it causes changes that are opposite to some of the changes, some of the abnormalities with PTSD, maybe it can be helpful. Huh? No, that's PTSD on the top.
Oh, excuse me.
So, and another effect is people may have affirming experiences can be an important part of the effect too, and change in cognitive distortions with more realistic perspective. So it's kind of both the idea that MDMA can remove obstacles to processing trauma and also maybe give some affirming experiences too. And as I said, there are other elements of other psychotherapy approaches tend to happen. And, you know, I don't think we need to spend too much time on this. You've got this in your handout, so, and we can talk about this later if we have time, but maybe we should just keep going. This just lists some of the overlap with other therapies. So, any questions about that quick run through about why MDMA for PTSD? Oh, I don't know if we have any. Okay, thanks. So this is just to briefly describe our first protocol and give you the results. Unless, has everybody seen the results of our first study, or some people not? Okay. This was a double-blind, placebo-controlled trial. Everybody had to have treatment-resistant PTSD, having had treatment with both an SSRI or SNRI plus psychotherapy. And most people in the study had had years of therapy and many different medicines. And it was mostly crime-related PTSD, rape, and childhood sexual abuse, but we had 2 veterans at the end, 1 veteran in the 20, and then 1 other veteran. As opposed to our study now, which is all veterans. And it had, so that was stage 1, the open label stage. Then we had stage 2 crossover, in which people who had gotten placebo, and everybody got the same thing twice a month apart, either placebo or MDMA, and along with all of the psychotherapy, the preparatory sessions, the all-day sessions with us, the follow-up sessions. And if they'd been randomized to placebo in stage 1, then they could elect to cross over and do the same thing again, but this time with MDMA instead of placebo. So it was like they acted as their own controls. And it was on 2 or 3 occasions. The protocol changed a little as we went along, but I won't go into those details. Basically, our analysis is based on 2 occasions, because that was our original design. The 3rd occasion added a little effect, but we're being conservative and reporting the effects after 2. People had careful medical screening, labs, physical exam, EKG, the psychiatric screening I mentioned by the neuropsychologist, and they had to taper off their psychiatric medicines. The session, the experimental session, either MDMA or placebo, was an all-day session with both of us. People then would stay the night in the office. There was an ER nurse and ER doctor on duty for 5 hours during the session. Halfway through, I let my emergency medicine boards lapse because I didn't think I needed them anymore. So halfway through, I went back and took the boards and got that back again. So I was able to be the ER doctor as a secondary role, which was not hard since the ER doctor never had to do anything. But the FDA did require us to have that. Now we don't have to have that anymore in any of the studies. But since this was the first one, they were being very cautious. And people would spend the night with a nurse in the office and then meet with us again the next morning for an hour and a half. And then we would talk to them on the phone every day for a week, meet with them every week for a month, and then do this next session a month later. So there were approximately weekly integration sessions afterwards for a month. So with people, we had a lot of people from out of town, so sometimes we would compress those and have a gap. But everybody got all those integration sessions after MDMA or placebo. The dose was 125 milligrams, and halfway through we got permission to add a supplemental dose of 62.5. We're not sure that that was any better, but we're testing that. And then, as I say, all these additional non-drug therapy sessions were a really important part of the whole thing, as we'll talk more later. And we had to measure blood pressure and pulse every 15 minutes and temperature every hour. We've now gotten permission to back that off to every half hour of blood pressure and pulse, but they insisted, FDA insisted on 15 minutes. So here are the results. In a nutshell, this is the clinician-administered PTSD scale, our primary outcome measure, which is like the gold standard for PTSD symptoms, same one that was used in the Zoloft and Paxil trials to get FDA indication for PTSD. So here's the CAP score. People had to have 50 or greater to get in the study. The blue is the placebo group, the orange is the MDMA group, and these are 4 time points. Baseline before treatment, 4 days after the first MDMA or placebo session, 4 days after the second session, and 2 months after the second session. So you can see that the placebo group had a significant change. This was statistically significant improvement in the placebo group. Both groups had an almost identical baseline means of just below 80. So 20-point drop in CAP scores was definitely an improvement. But as you can see, the MDMA group had a much larger improvement beginning 4 days after the first session and then continuing to improve. So by the end, there was a 33-point more improvement with MDMA than with placebo. And we can't really compare the studies, but just to put that in perspective, in the Zoloft trials that led to FDA approval, it was a 7-point difference, 7 points better with placebo than with Zoloft than with placebo, and we had 33. So it just kind of shows you it's a meaningful amount. And then this is stage 2, the people that got placebo along with the therapy. You know, it's not really just a placebo group, it's a therapy-only group, so they got all of that same treatment. This is the score, the mean score of the people that got placebo after the placebo sessions and before the MDMA. A little over 65. This is the score, mean score for that group 2 months after 2 MDMA sessions. So they also had about a 30-point drop in their CAPs beyond the change that they had with placebo. So as their own control group, it appeared that when we added MDMA, it made a difference. And this, the neuropsychological test we did there, I don't understand that well, but we have a really good neuropsychologist. And there were 3 of them, and they all, none of them showed any sign of decreased neuropsychological function. And there was a trend toward improvement, actually. With all 3 tests, this is a slide of the Ray-Bans, repeatable battery for assessment of neuropsychological status, I think it is. And that's the most comprehensive of the 3, but the graphs for the others look about the same. MDMA, purple is before, green is after, placebo, purple is before, green is after. So absolutely no decline in memory or other neuropsychological function compared to before and afterwards or compared to placebo. The long-term follow-up that we are hopefully about to publish, we went back and a year or more later, we repeated the CAPS and another one of the measures, the impact of event scale, IES-R, and gave people a questionnaire. And because the study happened over more than 4 years, the actual time of the long-term follow-up was at least a year, but it in fact was it ranged from 15 to 63 months afterwards, with a mean of 41 months. And everybody did the long-term follow-up. 3 people did not complete the CAPS or IES for various reasons. So I don't have a graph. So basically, a long-term follow-up, 82% had no longer met criteria for PTSD, still, a mean of 3.5 years later. Of the 3 who did meet criteria, 2 had a clear serious relapse with CAPS above 50. One was 60-something, the other was 90. Or 90, yeah, 60 and 91. The other person that met criteria still had a CAPS below 50. It was 33, but so had a partial relapse. So it didn't last for everybody. 2 people definitely relapsed. We heard about another person that also relapsed after that. But, you know, it looks like at least a lot of the benefit was maintained for most people several years later. Yeah.
Of the people who relapsed, were they exposed to a new traumatizing incident, or was it in relation to the original trauma?
The people that relapsed did say they didn't have a specific single traumatic incidents, but they said that they had very stressful circumstances in their life, so other kind of smaller traumas. They said they had done, very well for actually a couple of years in both of those cases.
Financial for one person, loss of job.
But they all, in the long term, in the questionnaire, they all reported benefit, mostly saying at least a lot, at least some of it had lasted, some said it had lasted and continued to grow. We have to, in one way, assume that the 3 people that didn't take the caps may have relapsed too, even though we don't think they did, because on the questionnaire they said they didn't. But even if we assume that they were relapsers, we still have, 5 out of 20 that relapsed, so we still have 75% who didn't relapse, even in the worst case. But in fact, the people that didn't take the caps reported a 4 out of 5 on mean benefit, and actually 5 out of 5 on duration of benefit. So, no, that's not the duration of benefit. That's not true. They reported about the same benefits, so they didn't seem to be a radically different group. But even if they did relapse, it's still a strong result. And no one said they were harmed by participation. Yeah.
Was this after one MDMA session?
After 2 MDMA sessions.
2 MDMA.
Yeah. Yeah, so here's the, this is just a chart of that. This is the mean CAP score at baseline before any treatment. This is the mean CAP score 2 months after 2 MDMA sessions. This is the mean CAP score 41 months later. Actually a little lower, but statistically no different. And this includes the people that relapsed.
I'm sure you're all aware of indigenous practice and how they will usually have a couple of events a year, major events, where everybody takes, I'm talking about the psychedelic cultures. They'll have a few times a year where everybody has a psychedelic experience. So I was just wondering if you ever thought of using that model and suggesting that model, people having some treatment and then maybe every 6 months or every year at least to have another treatment as an ongoing thing, like once a year.
Yeah, well, that's a very interesting idea, and we asked people on the questionnaire if they thought another session later would have been helpful, and they all said yes. It's probably not practical in terms of, the drug development plan and where the resources need to go for research at this point, because it wouldn't be so meaningful to the FDA. But I think, the idea is if we can push forward with this kind of study and get it taken out of Schedule 1, then it'll make it so much easier to study the kind of thing you're talking about, which I think would be excellent to study. Yeah.
How do these numbers compare with the follow-up numbers on the placebo group?
There was no placebo group at that point because 7 of the 8 placebo people had crossed over to MDMA. So there is no control group for this, which is one of the weaknesses of it. The one person who didn't cross over was that we had 2 strong placebo responders in phase 1, stage 1, one of whom relapsed within a couple months, but the other had a sustained benefit and said she didn't need to go on to stage 2, and then she still had a low CAPS in follow-up. So there is a control group of 1 person, and she had a similar picture as this. Yeah.
Was the lack of control group for ethical reasons or the difficulty of recruiting enough subjects for the trial?
I think it was a combination of the two, really. It would have been, it would have been harder to recruit to tell people that then they would have to, they would never get the possibility of the active treatment.
Well, actually, at the beginning, we had that.
Yeah.
At the beginning of the study, we didn't have approval to have a crossover. But after 5 subjects, we went back to the FDA and said, could we now, after you seeing what we have done, could we now have them cross over? So we had a number of people that didn't know they were able to get it later. That was very difficult.
Luckily, it was retroactive. When we got permission, we were able to offer those people, and they all took the option. So, but also, you know, if you're going to do a follow-up a year or more later, you'd have to, for a real control group, you'd have to control for other treatments, and we didn't think it would be ethical to tell people you can't have any other type of therapy or take medicines for this prolonged period of time. So it's one of the challenges of a long-term follow-up study for sure. Okay.
I was just wondering, like I've heard before that sometimes a placebo with the psilocybin studies has been like amphetamine, and I was wondering why you decided maybe not to use amphetamine or an active placebo per se.
Well, we've had a lot of discussions about this over the years, and it's an interesting question. The first study, the main reason was we wanted some safety data comparing it to inactive placebo, especially like for the neuropsychological testing, instead of a different dose. Now all the studies have a low-dose MDMA as an active placebo. And the Swiss study was 25 milligrams, followed by 12.5 for their active placebo. Our current vet study is 30 milligrams, is 3 doses, 30, 75, and 125, followed by half of the original dose, and then a crossover for the 75 and 30. You can cross over to a second phase with full dose. So we're trying to, because one of the weaknesses is that we can guess. In the first day, we were able to guess accurately who got placebo, although the independent rater didn't have any way of knowing that, but we still knew, so it was not a successful blind in that way. So we're thinking maybe we can confuse ourselves more with an active placebo, and using MDMA as low-dose MDMA is what we're trying. Okay, so any more about that before we move ahead? So now we're going to talk about kind of the principles of the therapeutic approach. And as I said before, it's not like we pulled this out of thin air. We just kind of organized and built on a foundation led by all these people and many others, and with influence by our own experiences. Two, we don't know if this is the best approach, or it's probably not. So we're not claiming that. We're just saying that we know that this worked in one study, and we think it's a promising approach to go forward with in the therapy. And then I'm sure much more can be learned about how to modify it, different approaches, and that kind of thing. So you've got a copy of the manual. And we've also written adherence measures so that independent raters can look at our videos. We video all the sessions, the preparatory sessions, the MDMA sessions, and the follow-up sessions. And we have a wonderful group of volunteers, Blue and Ray are 2 of them who are here now, who are Evan. Where's Evan? Yeah. Anyway, Evan too. And so that's an important thing for the research, that people can verify, are we actually doing what we said we're doing, and are we doing it with people that no matter what dose they get, or whether they get placebo, and are people in different studies using the same approach. So we're trying to standardize it in that way. And we've been working on this manual for years now, and when we first realized we needed a manual, we thought, there's Evan. We thought, we can't this can't be manualized. This is not that kind of therapy. It's much more intuitive and flexible. And so, you know, we stewed about that for quite a while. But then we came back to the fact, if this research is going to get anywhere, we need a manual. So we finally just came to the, you know, reality that, well, we ought to be able to describe what we're doing in a way that makes sense to people. So what we tried to do is have a manual that has enough flexibility to be consistent with what this therapy is like, but also have a way of standardizing in some way. And you know, the other comment about the manual is we certainly don't present this as like, this is a how to do this therapy for anyone out of the blue. You know, this is assuming that people have a background of therapy training, experience working with trauma. Because especially when you're working with trauma, it has a lot of challenges. So that's the spirit in which we present this. And this is a quote from Stan Groff, who, as we've said, has been one of our main teachers. And I want to read this partly because it really does apply in many ways to MDMA-assisted therapy, but also because just to notice and talk about the ways MDMA therapy is a little different from this, which is really written about LSD-assisted psychotherapy. But so there's a lot of truth in it, but there are also some differences. So what Stan said was the task of the therapist is not to understand rationally the problem the client is facing in order to use some specific techniques to change the situation according to some preconceived plan, but rather to mediate and facilitate the client's access to a deeper state of the psyche. Healing then results from the dialectic interplay between the individual and the collective unconscious. That's the part that's definitely true for MDMA in our view. The next part is a little different with MDMA. The objective is not a gradual exploration of various levels of the individual unconscious as in verbal Western psychotherapies, but facilitation of a powerful, transformative experience of a transcendental nature. So that last part also can apply too. People do have powerful transcendental experiences. But with MDMA, this middle part, verbal therapy, is a little different because there is more verbal interaction with MDMA-assisted therapy than, say, LSD or psilocybin, you know, during the sessions. And this has always been one of my favorite things that Stan ever said. And it's kind of about, you know, not over-rationalizing. Somebody asked him a question that, you know, he was trained in psychoanalysis, and he could have gone on at length about all kinds of theory about what was happening with the person. But this is what he said: I prefer to believe something is happening that I do not understand. And so that's something that I hold a lot in this work, you know. It will become apparent, you know, the inner healing intelligence is doing something, and I don't have to fit it neatly into a theory. So, in trying to kind of describe how we look at this manual, our daughter helped us out with a little animated thing, because I don't know how to make anything move on PowerPoint. This is actually going to move in there. So, you know, the way we look at this approach is that this middle thing contains the elements that are necessary to, like, adhere to this manualized method. And those are about the self-container, supporting the person's inner healing intelligence in whatever comes up, and, you know, quite a bit of non-doing, you know, not doing too much and not having to direct it. Those are essential elements of this. Then, you know, there are going to be parts that are very variable from one person to another, one team to another, and that's fine. You know, this manual makes space for that, so that, you know, the individual therapist's training and experience and style and intuition are going to be different for each person, and the relationship between the therapists, the nature of that therapeutic team is going to be different for each person. And that's great. We're not trying to replicate those parts of it. We're just trying to replicate the essential elements. So, for example, out of this experience might come up, somebody might say, I feel like I want to withdraw to keep from being out of control. And so in some circumstances, the therapist might be a little more active, something coming from over the therapist's own style. They might say something like, there was a time when that was a way of protecting yourself, to help them be a little more active in helping them make a connection. That would be something that you would probably do sometimes, or some therapists might do. On the other hand, a lot of the time, if somebody says something like, I feel ashamed, I must have enjoyed it, the response would be, stay with that. Let the medicine help you feel and explore it. So, for us, it's always a kind of a dance that we're learning each time, really. That balance between when you really just give supportive presence and encourage people to stay with their process and really honor their own healing intelligence as being the thing that is guiding this. A lot of the time, that's what we think should be happening. But then sometimes, making an intervention, a little facilitation of the process can be really important too. So it's flexible and there's that balance. And, as we said, I don't think we need to, want to go into this now, or should we? Yeah. Okay. Yeah, so the idea is each team will be different and each therapist will be different. You want to say something?
And I think with us, there's, with every team, you're going to have different ways of approaching the subject and the session. Michael brings his own strengths. He's very good with words and remembering poetry and cognitive approach, which is really helpful. I provide a lot of support and caring as a nurse. And those things are wonderful to use in this kind of therapy.
Yeah, and I think it's a fascinating topic in itself that, how does each therapy team learn to work together? It's a different experience with the co-therapist in the room, and what is their relationship, and how do they learn to complement each other instead of struggling with each other. And we've certainly had our share of struggling to work this out. We still sometimes do, but it's gotten much easier. But we've been together 40 years, so it's we've had time to work on it. But what we notice is one of the things that's very easy for me is trusting the process, and the shadow side of that is I may not pick up on something that does need addressing. And Annie has a lot of mother energy, is very attuned to the details and worrying more about, what could go wrong. And sometimes that's really critical that she brings in something that I may have been overconfident about. So, as we learn to deal with our own reaction to that, that difference, we learn to really appreciate it and try to use it as best we can. Sometimes we're better at it than others, of course, but that's one of the, I think, really fun challenges of this working as a therapy team.
In more conventional psychotherapy, therapists don't usually touch patients, but there's, along with other shifts in barriers, the barriers to touch may be down with this kind of therapy, and I wonder how you use that as a potential, or is it allowed as part of your protocol, et cetera?
Yeah. I'm supposed to be working now.
But,
This one? Well,
should we leave? I'm adjusting the level.
what? Doesn't seem to be on. Okay.
Oh, sorry. Go ahead.
Okay. How's that? Can you hear me now? Yeah, touch is allowed, and we're going to talk in detail about that. Thanks. So this is the shadow from Carl Jung's Red Book, and there are a couple reasons we have this here. Is for one thing, we are certainly working with people's shadows, with shadow energy and difficult things that come up. But there's also a shadow side to this approach to therapy. You know, kind of like analogous to what I was talking about me and Annie. You know, the shadow side of this idea that just trust the process and don't do anything can be that you may not do enough. You know? And the shadow side of the intervention is you may have a need to do more than should be done, and you may need to work with your own difficulty trusting the process. So it's a constant balancing, hopefully in a pretty relaxed way, but not always. So let's see. Let me look at this plan. I forget where we're supposed to be right now. Yeah, I guess we're good. Okay. Hey, I was worrying about it, and you weren't. That's and over time, you become more like each other. So there are lots and lots of things, helpful things to bring to this therapy, but two things we're going to mention that have been important to us are Groff's idea of the cartography of the psyche, basically what happens in non-ordinary states of consciousness. And the other is a little bit about the multiplicity of the psyche. The main thing being, there are lots of different ways to think about both of these things. The main point we want to make, though, is it doesn't really matter how you think about them. What matters is you don't pathologize them. And I think there's a lot of therapists that don't understand that very unusual things that can happen in non-ordinary states of consciousness are not the same as psychosis. And that also some therapists think that if people start talking about different parts of themselves, they've got some kind of dissociative disorder. And we don't believe either of those things in our experiences. It's really important to have an open mind and not pathologize these things. So that's why we're going to talk a little bit about them. So Stan's has this cartography of what happens in non-ordinary states, and there are four categories: sensory experience, biographical experience, perinatal experience, and transpersonal experience. So the sensory experience is, there can be changes in sensation, energy moving in the body, change in perception of heat or cold, hearing, all that can happen in non-ordinary states, including those with MDMA. The biographical realm is kind of the realm of mainstream psychology and psychiatry. Yeah, I love that cartoon. And that happens a lot in non-ordinary states too. People may revisit their childhood and talk a lot about the events that happened in their biographical history, including the trauma happened, at least a lot of it in their biographical history. There's also the perinatal realm that comes up in non-ordinary states. these are the 4 birth matrices that he talks about. Is, you know, for those of you that aren't familiar with his work, I really recommend actually going to breathwork training if you can, but at least reading his work. When he talks about the way the different stages of birth kind of form a template for other experiences, but also that people can revisit these in non-ordinary states. It is not true, as I was taught in medical school, that you can't remember anything from intrauterine life. It's very clear that you can, and that sometimes comes up. In our experience, it actually comes up a lot more with holotropic breathwork than it does with MDMA, but it does come up. And the important thing is to, you know, hold it with an attitude of non-judgment. And then people can have all kinds of transpersonal experiences. You know, probably less so than with psilocybin or LSD, but it definitely happens with MDMA. People can have out-of-body experiences and archetype. A lot of people have powerful archetypal imagery that we'll talk about more. And people can have very powerful spiritual and mystical experiences. And sometimes people report having past life experiences. Or as Stan always says, what people consider to be past life experiences. Because whatever you think about that, this is sometimes what people experience, and it's important not to discount it or insist that it's only a metaphor. You know, all these things have, and it's true of the multiplicity too. You know, people talk about parts of themselves, and people talk about these transpersonal experiences. On one level, you can, you know, work with them as a metaphor, and that's fine. And if you think that's all it is, that the people can't actually have these, but they're all, you know, psychological metaphors, that's fine. But what we encourage is not insisting on laying that point of view on the participant, just accepting it for what they experience it as being. And that can, and you know, that's really important, because often people feel that maybe this is crazy. So it's important to be able to validate these experiences for people. And you know, the multiplicity of the psyche, there are a number of systems that have dealt with that. Psychosynthesis, Roberto Ascioli was the earliest person in the Western world. And internal family systems therapies I've been trained in, voice dialogue is similar. But actually, you know, I think Jungian ideas of complexes can be the same thing as people are talking about parts of themselves. And also, you know, when people are having an inner dialogue with their parts, it's a lot like Jung's active imagination of, you know, dialoguing with figures from your dreams. So, we're going to talk about the about the specifics of the therapeutic method in 3 sections: introductory sessions, the 3 sessions that we have to prepare people, experimental sessions, is what we call MDMA or placebo sessions, and we approach them in exactly the same way, and then the follow-up and integration sessions. Any questions about that? I think we've caught up. Excellent. So the introductory sessions, in a way, are the most straightforward. They're the easiest one to write the manual about, because they're more specific things you can kind of check off that you've got to do. But there's also a lot of subtlety and variation, too. You want to talk for a while? I can do it all the time.
So, yeah, the first thing we do in the 2 studies is we have the informed consent meeting, and that is the first chance to meet someone. It is supposed to take about an hour and a half. It usually takes at least 2 hours. There usually are a lot of questions, even though we send the informed consent so people can read it. So we go through that. We get find out any questions. And the other important thing about our studies is a lot of our people come from out of town. So this is a real challenging experience for them, especially if they have severe PTSD and can't leave their house. They fly to Charleston, and now we have a research assistant, Sarah, who helps orient people to Charleston and their hotel. And so it's been an incredible help for us. And then they go for the psychological testing, which can be anywhere from 2 hours to 4 hours. We get that done probably the same day as the informed consent. We have a lab, EKG, and a physical exam. So it's a lot to do for people. It's challenging. And then what we try to do with people from out of town is have one more session with them before they leave, where we get to know a little bit about them. They get to know a little bit about us and start to feel comfortable before they go home. We won't know if they have met all the criteria at that point, but it's just easier when they're there for that time to start to have a little bit of a chance to get to know each other. And, Ingrid, yeah.
I just want to mention that the other issue for clients coming is that they have to come off antidepressants or SSRI or any other medication that they're taking. So that for some people could be an additional stress because their symptoms may be worse. And maybe you could address that a little bit more because for the MDMA to be effective without having to use a huge dose, they do have to come off that medication. So probably you'll talk about this later, but I'd be interested in your experience of how that is for people who have actually been using the SSRI to control symptoms. And then where do you use, benzodiazepines? Thanks.
Well, when they come for the informed consent, though, we don't have them go off their medicines at that point. We allow them to be on their medicines for the screening and the psychological testing. But then you're right, it does pose a lot of problems. So, you want to talk about that, Mike?
Sure. We've had kind of a range. Yeah, it's a really good point, and we weren't going to talk about it later, so I'm glad you brought it up, Ingrid. We've had a range of experiences from, we do phone screening before we meet with people to see if they are likely to meet criteria or if they want to participate. And sometimes in the phone screening, people say, oh, I have to go off my medicines, I'm not willing to do that. And we certainly never push anyone to do that. Often they say, well, I've been wanting to get off these things anyway because I don't think they're doing me much good. And then some people are kind of in the middle. I would like to get off them, but I'm worried about it. So it's important to approach that very carefully. And we always talk to their prescribing physician about it. And then sometimes, their physician or therapist tells them they don't think they should do it, and they don't do it. Other times we're able to let the prescriber or the therapist know that we're going to keep in touch with them and we're going to monitor the person carefully along with them. And then we, tell them, we tell the participants, we wouldn't want you to start this if you don't think that you can give this a good go and you don't think you'll be able to do it. But if you decide to do it, you can always change your mind. And the foremost consideration is your well-being. So if you're doing this and it's just too hard to be off the medicines, then what we want for you is to go back on and drop out of the study, and that's okay. So we try to do it that way. As far as anxiety and sleep are the main challenges for people, and what we often do is like if somebody's on longer acting benzodiazepine like clonazepam, we try to switch them over to infrequent lorazepam, so at least they have something that you can use sporadically. They can't be using that every day and then stop suddenly or they'll withdraw. But if we can still get them so they know occasionally if they feel they need something, you can use lorazepam. Then, it has to be 5 half-lives off the drug before the first session. So with lorazepam, they only have to be off for 2.5 days. And then we can use benzos as a rescue, quote, rescue medicine in between. And so they can take lorazepam occasionally in between sessions too, as long as they're off 2.5 days. For sleep, zolpidem is good because the half-life is 2.5 hours. So people can take, that's Ambien. People can take that up to like 9 o'clock the night before the session, and it's still completely out of their system. So they can do that.
They can take melatonin too.
Yeah, we encourage melatonin. That works for some people. So it's we haven't had anybody drop out during the tapering and not go on with the study, but we had one person the first day drop out after one session. It was a couple months later, actually. She had some delays for family reasons, but her depression relapsed. She had been on 2 antidepressants as well as lots of benzos. She actually had to go in the hospital to taper off beforehand, and she had a relapse of depression. Her psychiatrist started her back on antidepressants, and she had to drop out. Interestingly, she had a very good improvement in her CAP score after one session, and she said her PTSD was still better. She could really distinguish between the depression and the PTSD. With, she was able to go shopping, she was able to do all these things, but she was depressed. So yeah, thanks for bringing that up. Yeah.
I was just curious because you mentioned melatonin, if you encouraged any other supplements before, like 5-HTP or like multivitamins or fish oils or something like that.
We don't, just because we're doing the research for the approved study, so we don't tell people that they actually have to be off of supplements. They can use some herbal teas, but they have to be off all supplements. Well, melatonin they can use for sleep.
Okay.
Yeah.
Yeah.
And they can take vitamin C. They can take their vitamins, like vitamin C.
Yeah, the rule is no supplements not approved by the therapist.